Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 152. All of you keep writing to us, sending your requests, and most of the requests continue to seek further training and expertise in chronic total occlusion. So here we have for you another chronic total occlusion. Hopefully you'll get many of your doubts and queries answered. Hopefully you'll also learn lots of tricks. In the meantime, as a wonderful accompaniment, keep going to the app for the chronic total occlusion. You'll get many more valuable tips from there. With that introduction, let me take you to the Cardiac Cath lab where Dr. Sharma and Dr. Kinney are standing by. Sameen, good morning. Anu, good morning. More and more people talking about your apps.
Good morning.
Good morning. Unbelievable job with that. Each new app is bringing, and hopefully they'll be able to use the CTO app today too.
Yeah, so new wires going to show in there. And I know that, as you said, that we had taught enough people with the calcific bifurcation. You know, one of our bifurcation calcium of the LED diagonal actually have now received total 48,000 hits. 48,000. So between YouTube and CCC Live. So yes, calcific quite a bit. And Anu actually keeps saying also, let's go beyond calcium, beyond something. And request of the CTO. So our goal will be this year, we try to concentrate more on the CTO or some atypical things like some graft or Lima interventions and so. So we'll work on those because left main, the calcific lesion bifurcation we have taught quite a bit. And today, as a part of it, Anu will show some of the wire app and particularly the use of wires in this situation. And so, and we want to say something and then we start.
No, I think as the case goes by, we will show the slides with the wire features as well as the wire properties, which I think interventional should know so that they understand that they have it in their lab and which wire to be used in which particular situation. It's not important. I mean, CTO is the most important time that we know which wire to be used for what, but even when we have a difficult case, whether it's calcified or bifurcation, it's good to know the wire properties so you know exactly which wire to be used. We keep having these questions when we are doing live cases to other centers.
And the rest is our cath lab staff with the same usual, I would say, crew. And we have two fellows here, Shiv, Bagga, and Ollie. And will be helping out in this case. And rest of the cath lab staff, although cannot see right now, but you'll have enough time and exposure to see. Let's go to our slide presentation. So we get off to these are our kind supporters, and we are so happy for all of them. And these are our disclosures, unchanged. Actually, mine even decreased conflict. Further, as you said, 152 episode. This patient actually 67 didn't have any trouble until recently. New onset angina equivalent, not even chest pain, has dyspnea. Remember the latest OC criteria. They do not talk about the Canadian classification of the angina. They just say symptoms because we know majority of the patients have angina equivalent or dyspnea and has a positive stress MPI and does have a low EF. To begin with, no prior, as I say, hyperlipidemia and was taking only aspirin torostatin. He had a cath done in end of January, which revealed two vessel disease. Calcific, 80% LED, proximal to mid LED and 100% mid to distal RCA, which we are going to show today. And patient had a rotablation plus DES of the LED, did well, but symptoms still continue. Now has added Zestoretic, metoprolol XL, isosorbide, and clopidogrel. So today plan is stage PCI of the RCA CTO via Antegrade. If fails, then retrograde approach with dual injection. That's what we have. Always when you work on and this is our OC criteria, which is we show it in every case. In this particular case, clearly because of the high risk finding and it's a non-LAD and patient symptomatic on double drug is appropriate to use. So now we want to just show angiogram and then we'll show the wires. Yeah. You guys come, one of you inside. Yeah.
So this is the LV-gram, hypokinetic inferior wall, basal moderate to severe. So this is the left side, less than 30 distal left main, circ looks non-obstructive, LAD PCI has been done. And I think if you think about retrograde, look at the septal. We are talking about the probably the fourth septal, way further down in the distal
Right.
LAD. Yeah, that's what I meant. It's too distal, but this is
Yes.
the always inject the feeder vessel, and then you see after the large RV branch, you see there's a total occlusion, and it's a bridge collateral which is not well appreciated in this view, and that's
Go to
why
the
I'm
RAO,
going
yeah.
to the RAO view. I will just take a picture here to show the bridge collaterals. You don't need dual injection right now.
Yeah, now
So
we
it's
see it. Right.
reconstructed vessel.
So, Samin, a quick question for you. The first index procedure was done on January 28th. That evening itself, you decided, look, this looks to be an excellent CCC live case, and that's when you scheduled this patient for today?
Yeah, well, actually, Dr. Keeney is master in that. So
Yeah,
as soon as the case
unbelievable.
was
What logistics.
like the bridge, so right away decided that this is a beautiful case for teaching and so. And other point is, a lot of people may say, well, there is a severe hypokinesis of the inferior wall, but patient has significant inferior wall ischemia. It was the anterior ischemia, enteroapical, and inferior is both ischemia and infarction. It's about half ischemia, half infarction. So it's not a completely dead myocardium. Because if it is a completely akinetic and there is no reversibility, then you have to take the more advanced tests like cardiac MRI or the delayed perfusion 24-hour thallium redistribution to see viability. But once you already have ischemia, there's no need for viability, and you saw how big the right coronary artery is. It fills by so many collaterals. Look at that. Mega right coronary artery by so many collaterals. It's filling by, oh, yeah, 1 second.
This is a
here. Look at this mega right coronary. I'm saying that LAD is there. Probably in this case, I would say LAD probably supplies the 40% of the myocardium, and 50 or 45% comes from the RCA, and circumflex about 10 to 15%. Look at the big right coronary. Okay.
Completely agree with you. Samin, both axes are from the femoral sides?
Both femoral sides. Okay. And we go to our slide presentation, and Anu, before we start, we'll have the plan that what kind of wire and what you are going to do. Yeah. Okay. Tell your plan, and then you'll start and we'll continue.
We put the downloads. I think we wanted an update on the downloads. We are about 54,000. Where is it? Next slide. Okay, go next slide.
Okay. Let me just see, download for free.
Guide wire download for free. We released it November 4th.
CTO.
Keep going.
No, but I'm moving this. Huh?
Yes. Press.
All right.
Yeah, there is no download. This is wired off.
What a wonderful demonstration.
We have the download fly. It will be in the end.
Oh.
Okay.
So this is the CTO wire escalation. This is just a sample. I think always give you a bird's eye view. What are the wires you need and what are the wires we need to learn? So as usual, we always go with the soft polymer jacketed soft tipped wire, which will be the fielder right there, first one. And we will go with various fielder family wires, what they are. Then it's up to the operator. I mean, many people, I'm told, still like to use pilot, or they would go for Gaia, the next step. And of course, you have seen me using Miracle Pro, which is old school. If you see, it's not tapered. It's a not hydrophilic, but hydrophobic tip. There are good and bad things about this each, because when you have a hydrophobic tip, your tactile sensation is very good. But since it's a older generation wire, your one-to-one torqueability is not there. Then, of course, the tip load increases with Confianza, which starts with 9 to 12. We put the other name because outside US, they are also called as Conquest. Progress, 200, various tip loads are there, but many people could use it. It's a combination of Confianza plus fielder. It's a polymer jacket, but at the tip, it's hydrophobic with a hydrophilic coating. Then of course Hornet and Astrato with a very high tip load. If you see that 20 and 40 with the Astrato.
The real needle.
Yeah.
Yeah.
We
Look,
call it
remarkable. And what I find so much challenging here is that every few months you have to update these. New wires will keep coming, and so there's a constant work for the people creating this. But beautiful, you know, it's such a lovely illustration of the method. And is that the strategy today? Would you be going exactly down this route as you do this case today?
yeah. So if you see, these are the, you can see all the wires that are there. Let's go to the next. We just went through. This is just telling you the tip load of each wire.
Excellent.
Tapered, not tapered, and tip load. But this way you will see in the wire library. And the great thing is there's a search function. So when you go to the app or on the website, there's a search function. You put any wire, the wire will pop up on the library. So this is the fielder that we always use. There are various other fielders, which is fielder FC, mostly for the retrograde, because you see that the tip load is very small. Fielder XT, XTA. Many people like using this for so-called micro channel to surf through the even when you're doing retrograde. So keep. Yeah, that's where you are. And this is just the miracles which we use, which is good one. I think for people who are just starting, nothing wrong in using either Miracle or Gaia and get used to those wires so that you know that you are safe. Miracle actually is safe in the sense, since it is not hydrophilic coating, your one-to-one torque is not the best, but you know you can do the drilling motion gradually for early learners. Yes.
So this is a little delayed today. Okay. Then the Conquest and the Confianza family. But
Yeah.
Miracle of the various, we use by and large only Miracle 6.
We use, yeah, that's the same thing. I mean, you have to use this and try to keep one or two wire. You cannot have the whole family in the lab. So we have 3 and 6. We don't have the 9.
Yep.
Then we have Confianza 9 and 12.
Yep.
That's how we have kept it.
So Anu, 8 of these wires you have shown with increasing tip loads. Do you think sites doing a lot of CTO should have all of them, or maybe if you were to eliminate 1 or 2, have at least most of them?
No, I think they can have 2 of each
Category.
family.
Yeah. Okay.
Yeah,
Excellent.
so that they know. Like here we have Hornet 14, we have Astrato 2040, and Progress we don't have all of them. We only have Progress 200. They gave 120, 140, but we don't keep all of them. So that's the way it is. So also it's easier for operators to remember, what they have. And also for the staff, so they know, these wires have to be kept in a particular way, so that when you're asking, they can pull it out of the shelf immediately. Yeah.
Yeah. So, and these are the over-the-wire systems which exchange catheter, micro catheters. There's somehow delayed in the today. Maybe the batteries. Yeah. So Turnpike.
So we have always shown you Fine Cross and Corsair. So I mean Fine Cross most of the time because we've used to it. Today we are going to use Corsair. Yeah, Corsair comes again 130, 150, 150 if you're doing retrograde, because you need a longer one to go from the contralateral side into the main vessel. But we'll start with 130. If we have to go retrograde, then we have to change the length.
Yep.
I think we can start.
Various Turnpikes. Yeah, let's start. Turnpike actually has a big series.
Yes. What's the download he has?
Yep.
To remove
It's
that
coming.
Diwali special.
It's all
down.
automatic. Yeah. Yeah. Okay.
So the download we have is 54,362. Yeah.
Wow.
Fantastic. Congratulations,
And counting.
Samin, the first question
Good.
has come. Could you
Tell them
attempt
change the
this
battery. So bad.
with wrist access?
Yeah. Yep. I think at least contralateral, because yes, I would say the people who are expert with the radial, they will do this case with the bilateral wrist. But remember, we showed the data that in the registry, bilateral wrist for CTO is used in maybe 7-8% of cases. Majority of them are basically femoral, about 40%, and about 30-40% is one femoral, one radial. So if we had to do this case, we'll do a left radial and right femoral.
Yeah, and other thing, we are with 6 French, but majority people will go
inside,
7 French or 8 French when they're doing the CTO. So, I think when they have a large bore axis, they may want to go groin for the larger axis, and the other one, they could go 6 French radial.
Okay. All right. So we saw that you see the little channel on the RO, but right now we are going with the Corsair with the fielder wire.
Yeah.
Okay.
Now what, you want to put it on the top for me? Wait. I just have to have a road map.
Yeah.
Okay.
And there is not much calcium at the level. There may be a mild or mild to moderate, but it's there. But more is the proximal right here.
So we have Corsair and then fielder. Also look at the tortuosity of the vessel proximal. Yeah.
No, look, Anu, before the case when you mentioned the bridge collaterals, I think that is going to be your largest challenge here.
Some die.
So normally your preference here would have been fine cross. Why choose the Corsair?
There's a tortuosity and a calcium proximal.
Got it.
Yeah. So now I will have to chain the wire or chain the curve. You see here, I am preferentially going to a small branch or the RV there.
And you need a stiffer wire now.
Yeah.
You Miracle 2 or Gaia 2 or 3? I'm Miracle 6 or Gaia?
Give me Miracle 6.
Okay, Miracle 6, please.
So now, let me tell you what's my thought process for Miracle 6 versus Gaia. So Gaia comes with a preformed curve. And usually, when they have made that curve, it's not the best for us to change the curve that comes with it. It's a very short, almost 2 millimeter curve. Whereas here, if I go back, I have to make a special curve. If you see this, look at the vessel now. The fielder is taking me to the RV branch.
Right.
So I need a larger curve to get into the main RCA.
Yep.
So that's
what
I'm going
actually.
to make.
Yeah.
That I will be making it with the Miracle.
Okay, ready?
Yeah. See it very nicely from our ceiling camera.
Good. Okay, now Miracle 6 going. What will be the next wire after this?
I can have the Gaia 3 ready. Otherwise, yeah, Confianza. Let me see if this, I'm not changing, and same thing, we stay in one view. No need to keep.
Yeah.
And using exactly the wire escalation algorithm as in the app.
Yeah.
Okay, so now we see the different shape, but the same result.
Yeah.
No. And go to RO. I think this one will be the RO case.
Wait, let me just see if it turns down.
Yeah. So it stays there. Yeah. You have to bring then your Corsair to the tip.
It may, when I advance.
It takes it further down the branch.
Right.
Yeah.
Exactly. So I think this is the case, is the good one for the RC, the RAO. You tell me when you want to go to RAO.
Let me see if this moves a little further. See, one good thing about this is the one-to-one torque is not the best. We are in the
Gayatri.
Yeah.
To my two research fellows, David Zerpa and Ashwini, good morning. Thank you for joining us.
Gaurav? See the fluoro first. Yeah. Let me give you a little die. Yeah.
So a large contingent of technicians led by Pawan are watching us, and mentioning that this is an excellent teaching case. We absolutely agree, and hopefully there will be many tricks to learn.
Beautiful.
The thing is, when you are in the RO view, you don't know if your guide is coming out.
Yeah. That's the biggest issue with the RO view.
Yeah, I cannot remember more than a handful of cases where we have been showing the RAO view, but in this particular case, clearly beneficial.
Okay, I think I have.
Although sooner or later you'll go back to the LAO, I think.
Yeah.
But,
Once it's a little progress, then we
right.
definitely.
Exactly.
Go to Gaia, right? I think we are in that area. We may have to go into the.
We can take a little
subintimal
picture when
and,
we want. Yeah.
Anu, if you're proceeding with the Gaia, then we would like to see the pre-shape of the Gaia and.
Listen.
So this is poor man's IVUS. You see this? What I'm saying is when you bring your shutters in, not the lung shield, just the shutters. We are subintimal.
Yeah.
Okay, get the Gaia.
Right here. Yeah, 3. And then they want to see, put on the hand with a small tip, which is already there.
So if you can see here, the tip.
Yeah, they can see.
Do you need a blue background?
See it a little more if we can focus. Perfect. Excellent.
Yeah.
Yeah.
A very small tip, yeah.
Okay.
Coming
So
out.
have you had times, Anu, when you modified the tip of Gaia?
Yeah, when we modify the tip, it's not that easy
Kind of
to
loses,
introduce into
yeah.
the, and no, not even that, very difficult to introduce into the microcatheter.
Maybe use a little needle there to do that. But exactly right. So this would be wire number
3.
3. Yeah.
Yeah.
Okay.
The same escalation which we showed.
Absolutely.
Fielder. Yep. Then your second is Miracle. Then you go to Confianza versus the Gaia 3. So want to take a little picture?
See there? We are subintimal. Went into a bridge collateral, right? Looks that way. No?
No. I think we make an additional curve on this one.
I want to go with the.
And go to back alley.
Yeah.
So how would just speculating the difference between fine cross and the corsair exactly in this moment as you're doing it? Do you think fine cross?
I may want to go back to fine cross.
Yeah, I had a feeling because the corsair kept directing the wire more towards the RV branches.
Right. Yeah. So I mean, biggest thing Corsair is 1.3 French compared to 1.8 of the our fine cross. But let's get a fine cross.
We have it.
We have it. Good. So that's one of the region. And while we are getting it, let's go to our some presentation. So we getting now. Tell us what you're planning now.
No, I will go fine cross.
Okay, and
there,
which
go
one?
there.
Okay.
And then I'll make a decision whether I go back with the. I think you were right. It took us. You see that it took us outside.
Put a fielder wire again.
So.
Okay. So basically, while we are getting it, I'll just go through our two topics. One is the recent interventional trials of 2021, basket small 2, BioRite China trial, and combined OCT FFR. The first two are for the small vessels. Then our focused review of the month is the complex parameters and PCI outcomes, defining PCI, complexity and risk of in-hospital outcomes. So basically, we talk about the basket small 2, which we presented here in the setup. Now, do we have to point in a different way today? It's not moving. Yeah. So this actually I presented as a part last year, basket small 2, which was the long-term efficacy and safety of drug-coated balloon versus DES in the small coronary arteries. 28% were the first generation DES in this, with the 3-year of the randomized trial, non-inferiority, which is assigned basically a drug-coated balloon or DES. No. No, I want to be moving myself. So as you can see here, so overall 3-year outcomes were base, identical, death, MI, TVR, stent thrombosis. So DES actually had 2% versus 1% stent thrombosis. 1% didn't make a difference in overall outcome in terms of significance at a 3-year. So within this study, what we found basically was, as you can see, on the left side is the MACE, and then if you have put a drug, after the drug-coated balloon, you DES, your event rate was very high. That was done in a small percent of cases, and the overall message was that both were identical. Now, within from the same group, basket small 2, this latest publication was for diabetic patient. Is there a difference in diabetic patient with a drug-coated balloon or drug-eluting stent in a small vessel? And these are the non-fatal MI and all-cause death, as you can see, seems to be none. One, the diabetic have higher MI and higher death, but no difference in the drug-coated balloon or drug-eluting stent, DES. But what was clear was here. That is patient on the top without diabetes, bottom with diabetes. Look at the TVR, 9% with the drug-coated balloon and 15% in the small vessel with the DES. Mind it, only issue is that about 28% were the first generation DES, which we know have a higher event rate. So on the right side, clearly the TVR was much lower in the patients who got the drug-coated balloon diabetic versus who did not, versus DES. So clearly that there was lower rates of MACE are similar in the drug-coated balloon and DES in a diabetic and non-diabetic. In diabetic patient, need for TVR was significantly lower with the drug-coated balloon versus DES. So this was the basket small 2. Now question is, why that is? Possible explanation, no metal or polymer left behind, no long-term stent thrombosis risk, and abbreviated DAPT duration. Probably all contributed to a better outcome with the drug-coated balloon versus DES. So there is a nice editorial that is the way to go for a diabetic and a small vessel. Unfortunately, in America, at least we don't have a drug-coated balloon. And there are many trials now, the Bello, Picolito 2, Restore, Sequent Please Registry, and of course, Basket Small 2, all, and there is a meta-analysis, all actually pointing out to the use of drug-coated balloon, particularly small vessels, and even in some large vessels also. So, Anu, we are ready for you?
No.
Okay. Okay, now let's continue the second part.
Are you? No.
I mean, that is actually, as you proceed to the BioRise China, this has incredible, massive implications that DCB could be better than DES for diabetic small vessels. I mean, this is a very large number of patients we see.
Yeah. Yep. And not one trial, some of them Picolito 2, although that was not just diabetic. So overall equal, but diabetic definitely seems to have a better benefit of the drug-coated balloon. And I think part of that is the metal and polymer left in the small vessels is more troublesome.
Right. Like this guy.
Yeah. You'll tell me when to come. Okay. So now let's go to while they're making this. Second is, again, we went to the next level now, bioluminescent coated balloon. Earlier we have different, whether it's a paclitaxel coated balloon or sirolimus. Now here the bioluminescent coated balloon versus plain old balloon angioplasty, POBA, in small vessels. Okay, so now you say, well, the DES showed to be comparative. Why you want to go in particularly this setting? So this was the whole concept, was that the polymer-free bioluminescent-coated stents have shown excellent safety in leaders-free Onyx 1. The question is, what about the bioluminescent-coated balloon? And this is where the whole concept was. And in this, 106 patients assigned to drug-coated balloon and 103 with the POBA. And basically the primary endpoint was a late lumen loss and TLF, as well as patient-oriented outcome and restenosis. So basically showed that compared to balloon angioplasty, the drug-coated balloon have a better lumen, less late loss. As you can see there, very important with the red bar. So clearly, the late lumen loss was significantly lower with the drug-coated bioluminescent balloon. These are the individual endpoint, lower restenosis. So seems to be that compared to the small vessel, bioluminescent coated balloon, in the small vessel compared to POBA, bioluminescent coated balloon was superior. And so you say, well, I'm not going to use a balloon. I'm going to use a small DES. So I think that area remains open. That should you use a drug-coated balloon or drug-eluting stent, I don't think anybody will use a balloon only or POVA or PTCA. So that's where it became very clear by the BioRite China trial. No. So now we go to the third trial of the publication's point of view. That is the combined OCT FFR trial. That is a thin cap fibroatheroma predicts clinical event in diabetic patients with normal fraction flow reserve. So we know that people with a normal FFR have an event. So this was the OCT study with a follow-up. The patients who had normal FFR, means FFR more than 0.8. But is there any parameter on the OCT which can predict the subsequent clinical event? And this is basically here, the patients who have less than 0.8, they got the PCI, revascularization 93. But 390 patients who have OCT, 292 had a no thin cap fibroatheroma, and 98 had a thin cap fibroatheroma, and these patients were followed for 18 months. And what did we find? Very interesting. Look at the hair. Even patients, these all are FFR negative, should not get any PCI and did not get PCI at the time 0. So key is that TIC-FAR negative, if there's no thin cap fibroatheroma, even in those cases, look at the lipid plaque. It's almost 60% of the time. If you're no thin cap, you still have a lipid plaque. If you are the thick cap, if you're thin cap, which is the TCFA positive, everybody had a lipid. But just want to emphasize lipid plaque, that even patient with the thick cap, the 60% on the OCT had the lipid plaque. Now, fibrous cap thickness, we know the thin cap, we say less than 60 micron, was present in the TIC-FA positive, and it was 151 in the TIC-FA negative. Rest, the macrophage infiltration and all that shown here, clearly higher of those parameters in the TIC-FA positive cases. So what does that mean? Look at the event rate of death, MI, TLR, hospitalization. 3.1 if there is no TIC-FA, and if TIC-FA is 13.3, which is 5 times higher than the original. So key is that presence of TIC-FA in FFR negative patients predicted subsequent event. So very, very interesting combined OCT FFR trial. Individual endpoints are shown here, that not only the target vessel MI and spontaneous MI all were higher with the TIC-FA positive. So this is the observation. They did not have PCI because FFR negative, you could not have done the PCI in these cases. But very interesting observation of this study of the combined OCT FFR trial at 18-month follow-up. There have been some papers in the past also, and this is a central figure emphasizing that how patients group A, which is the green, TIC-FA negative, and TIC-FA positive red had a higher event rate with a nice central figure of the European Heart Journal. So clearly this field of the plaque characterization, those who are going to give an event, has come up to the center stage in last few years since its inception as a high-risk plaque almost long time ago. And that is basically that this is a finding, and we know the vulnerable plaque overall data from Nagvi in 2003 at the tip, intravascular ultrasound, thermography, OCT, near spectroscopy. So that is in a selected patient you can identify the vulnerable plaque, and over the years, the studies have done, and particularly in last, I would say 4 or 5 years, the natural history studies establishing feasibility of the vulnerable plaque detection by the Prospect, by Greg Stone, Waxman, the lipid-rich plaque, Pratty with the LED, again OCT, CAD combined OCT FFR, which we just showed, and the Prospect 2, again with the NIRS and OCT, all have looked into and predicted that these are the vulnerable plaque. The only question comes, what we should do it? How should this vulnerable plaque be treated? That's where the whole issue comes down, that whether you should do a revascularization in these patients or not, this is up still to be decided, because we don't have any prospective trial, although Prospect 2 in the absorbable stent, absorb group, they did better. So revascularization for these vulnerable plaque, besides giving your antiplatelet therapy, lipid lowering therapy, all CAD risk prevention, you still need to have some more modality whether revascularization should be done. But we need a prospective trial. And you want to come back here, or?
No.
Why don't we come to the NGO? So you tell us where we are.
Yes. Many viewers exactly wanting a follow-up on what's happened. Did you change to the fine cross?
We changed to the fine cross. I think the initial one gave us with the Corsair, we were subintimal. I think we are in the still in the same area.
And what wire do you have now? Is this
now
the
I
Gaia?
progressed, no,
Okay,
Gaia we tried. Progress 200.
Progressed. Okay.
Some dye. You see that there's a little bit of dye staining outside the vessel.
And go to RO view again, or no?
Let me see. RO. I want to.
Yeah, here is because of that overlap in the bridge. Yeah. So other question will be that at what point you want to go to the contralateral.
Okay. You want to go to the RAO now?
Retrograde, yeah.
A little bit.
Let me get to the RAO, 1 second.
Why is he moving around?
Floor.
Some dye?
Yeah, 1 second.
Yeah, not much progress there.
Yeah. Think about the retrograde.
Okay. This wire is not the best.
And this is the progress 200?
Progress 200, yeah.
Samin, 150.
Three fascinating clinical trials you demonstrate, each with its very relevant implications to what we do. But I'm curious that was there a editorial following BioRise China? I'm just surprised anybody would do a trial with POBA.
That is true. So what happened is, it was just presented in TCT last year. It has not been published yet. So wherever it will publish, then editorial will come. So far, it is only the presentation in the TCT.
Right.
What do we need now?
Get me conference at 12 before I change once.
Okay. Yeah. Conference at 12. Yeah. So yeah, but again, I think that was just POBA alone. We knew it's not going to work. And particularly if you have balloon angio, if you have diabetic patient, which is about 30%, they traditionally have shown that definitely does not work whether small vessel or large vessels.
I mean, a truly progressive trial that you're using biolimus instead of paclitaxel. Towards that, such a wonderful idea and a well-performed study. Just that the comparing group is just. Because that's not
a practical. So if
it doesn't make
I would
sense.
say, if would have been biolimus compare with the paclitaxel or something, means established drug. We know you don't want to use the DES, that use the other variety of the drug-coated balloon. So that's what they should have done. Sirolimus or paclitaxel. Sirolimus is the sequent Q please balloon.
That I suspect will not be done for a while, but at least it could have been compared, I think, with the just a regular DES.
Yeah, that's true also, yes.
But the real, I think, the implications of the basket small 2 are wide-reaching,
Right.
and
Yep.
I mean,
And
as you were showing it, I kept thinking, I said, why would it make okay, we seem to have made a lot of progress there.
well,
I don't know.
right or
Whether
wrong,
we are
that's we have to see.
subintimal, whether we are progressing
You want to
on
give other injection? Yeah, contralateral. Yeah. No, there at least they should use a bioluminescent eluting, which is polymer free. Yeah. Good. Polymer free stent. So that they should have compared with that. Yeah, you want to take a cine? Then only you'll see.
very intriguing where it is. I mean, the wire is moving very freely, the distal tip. Not sure. Probably subintimal, no?
You have to go antegrade also a little bit. So we know. You have to inject both.
Complete dual injections, yeah.
Yep.
Because the bridge collateral also is doing. Do both, yeah.
I'll do first retrograde. You do retrograde.
Go.
I know. Yeah. You do in first.
Antegrade. Okay.
No.
Let me see
It goes
subintimal,
and I'm not so sure there is a possibility of a re-entry there.
Once there's tortuosity,
yeah,
right? Then
tortuosity and the bridging collaterals. It was your gut feeling was a good one, Anu.
Yeah.
Gut feeling was a good one. I had spoken to Dr. Kinney as she was going to scrub in, and she mentioned that is concerned about the bridging collateral. Samin, I missed one of the slides on the basket small 2. What was the mean diameter?
This was like 2.25.
Okay.
They're small, they're truly small vessel. But I would say the BioRite China should have been with the bioluminescence coated balloon with the bioluminescence drug-eluting stent, which is the polymer free. That's the one usually the leaders.
Yeah.
So that would have been the real sensible trial, in my opinion, compared with the balloon angioplasty only.
Would have to do a quick search on the sites. I wouldn't be surprised somebody is
doing it now.
Doing it.
Yeah, has to be. Yep. Okay.
I mean, this won't this be at least 10% of your PCI cohort, the diabetic small vessels?
No, I would say more than that. More than that. Yeah. Oh, yeah, definitely.
So very important.
You are retrograde? Lot of PVCs. Anytime you have some PVCs, that basically means that you probably have gone a little epicardial and
so this would be such a fascinating polling question at this stage. Do people think ready? It's time to move?
So now they just die. Yeah, I think retrograde.
Other thing
we have 6 French
vessels. Just try with the fielder whisper now that you created.
Okay, then whisper. Yeah.
Before we go.
Let's get the whisper. Yeah. So many times we'll try. With the multiple dissected channels, the whisper wire, by its virtue of the quality we have seen, it goes through.
I need a VL guide quickly.
A very, very fine observation by, I want to get the full name right, Farzad Shanshai, who said that look, antegrade injection must be very gentle, otherwise it's going to extend the coronary dissection. A very good point, Farzad, noted and disseminated.
Yeah, and clearly try to not give with the pressure injection, and just do a very soft 1 cc injection, as you can see here.
Yeah, remarkable observation, exactly what you have demonstrated there.
Yeah, and both actually, one, and secondly, chance for the wire migration, perforate the VTAC, even VFib, because of the no die issue, right? That no clearance of the die, and of course, myocardial blush. You want to go caudal view a little better? That's a cranial.
The other fascinating observation can be a lot of these cases are stopped here. You bring them after 3 months, and it's created a beautiful channel.
Channel, yeah. No, that's absolutely the part which we have demonstrated. Yeah, this actually looks a little better right now.
Okay, at least the direction is.
Yeah.
But
No.
here we go
Now
back
it
to the
goes to the
false
same.
lumen.
Yeah.
False
Yeah.
lumen, yeah. Anu, so many people have complimented on the app and on the wire escalation strategy and the algorithm. Truly, truly remarkable, and hopefully more and more people can go through this strategy, benefit from it, and I have never seen an illustration of the wires done so nicely. And not only that, even it's a guide to anybody. I mean, even the manufacturer is listed.
Go.
Same thing, right?
Yeah, exactly the same, I think.
Oh, right here, see that?
I mean, I think it goes goes
Same
subintimal even
place
much
where
higher.
we-
Yeah, much
No,
higher.
the first one that we did.
Yeah.
Here has to get into the lumen.
I think the contributor here
Is our
is the Corsair, because that was behaving very strangely, kept directing the wires. So whichever wire you use, irrespective.
no.
And see in the RA view the
Give me
direction.
the fielder.
I do not have
Another
an
fielder.
ability to poll the people here.
You're a good fielder.
But
Your
Some
fielder is okay.
diasis there. If I'm in the true area, then do I just go with the poking ability? Confidence at 12 right now. Confidence at 12 you have?
But do you want to go to RA view for that?
No. RA also killed it, I guess.
Okay. And to make a new curve.
Anu, at this moment, when you are proceeding to further, actually, it's not escalation from progress to confianza, is actually slight reverse care, but the intent is you still think there is a antegrade cap there which needs to be drilled through.
Yeah. I think what happened is our like you mentioned, the Corsair
Right. Was the
culprit
initial
took us a little bit outside,
Yeah,
so we are in that subintimal channel still. So right at this spot,
So at
I
that
may have a
with the subintimal
re-enter. I want to re-enter
okay,
here.
okay, then
But
that's fine.
progress 200, knowing that your one-to-one torque is not the best.
So
I
would
tried it. It did not help me.
Would there
And now
be
you are
a-
going with the confianza 12.
Yeah.
What about the use of the pilot here? Would that make any sense?
Retrograde.
Could the pilot, polymer jacketed, good wire, but
This is taking us back and back into the same area unless
the other thing is get me Hornet before I change. That's it. The last. Here I need to get in right here.
you don't think it's even higher than that? I think you're already with the microcatheter already in the, not sure.
Now see a little more.
No,
PVCs here.
No, it's not. It should be going easily.
Yeah. No.
Give me the Hornet. Otherwise, then we go to the.
Yep. No, please. You want to see retrograde a little bit? No.
Antegrade little die, so I know exactly where. I'm pulling back.
Mm-hmm.
Oh, there.
It definitely makes the curve like that.
Mm. So, you have the hornet ready? Some antegrade die. Mm.
You want to see this? It'll die again.
Mm-hmm. Hornet? This is 14 now. First time we are going above. Well, like it outside. Yeah.
Anu, when was
So
the
far,
last CTO where you used the Hornet? It's not often I have.
no. Yeah,
We
you're
use
right.
maybe 2 per month, right?
Yeah.
About 30.
Usually with our 2-3 escalation, we are crossed.
Right.
Yeah, this is.
Done?
Yeah.
Okay.
This is a Boston wire. Though they say they use Asahi engineers to make this wire.
You know, would be very fascinating to see. I actually have a couple of exceptional CTO users in Japan. I'm going to query them as to how different is their portfolio of wires. You know, but all that, the real advancement and the edge which the Japanese had, I think between Bill Lombardi and the other Americans and our own exceptional CTO
Can you
operators,
give
I think that
retrograde picture?
Yeah. You want to go some
that gap
different view?
has been narrowed.
You want to go epicranial so we see a little?
I don't know. This is the same view you saw everything.
No, this is we are in the
21:15.
caudal. We need to go to cranial. Yeah. These
Anu,
should be
just
21:15.
just to give you a
Yeah.
feedback, a chorus of people, including Dr. Harris
Retrograde.
Nagao, they are all
Okay.
saying it's time for retrograde.
Okay.
Okay. I'm injecting first.
I killed the vessel enough. Okay.
Again?
Yeah.
Yeah.
That
Yep.
does it, I think.
Okay, now you want to go to the other side itself?
Yeah. We have it there. Go with the VL. We have the Corsair, but we need a different Corsair.
Yeah, we have 150.
Yeah.
So the key here is, I think, a decision point. At this point, does one go retrograde or does one stop?
I think let's see the retrograde pictures. We're getting the new Corsair.
We'll try retrograde.
Sure, absolutely.
We'll start the timer. This is the time you start the timer. We'll see how the retrograde wire goes. You see that septal is not a healthy septal either.
And you're planning to
Very
go into
collicular.
the distal, the third or the fourth septal, no?
Yeah.
Yeah, the other septals all have been stented. Not
Good.
that we
Yeah.
can't go through it, but there's no connection.
Connection was third or fourth septal after the stent anyway.
You have it?
Yeah.
I'm going up.
Yeah.
So when you were doing, Anu, the procedure for the LAD, were you already kind of having that in mind that, look, at some stage we may have to go retrograde CTO and Did that factor into your strategy of stenting the LED?
Good.
No, we did think about it, but we also have done cases with the stent struts.
Absolutely.
Yeah, so
Look, invaluable teaching case. Here is
Find
something
out what
else.
cases room, this one and 6. Good.
So Anu, you'll find it fascinating. So Dr. Sohail Rashid says it's good seeing you watch a
Huh?
torquing device.
Side now fielder XT,
So
right?
everybody has
No,
felt
no.
that your fingers were doing all the work.
Okay.
So
These
even you had
wires, you have to remember, these are very old generation wire. Your one-to-one torque doesn't exist. That is with your Hornet as well as your, though they said, and with Progress 200. Fielder?
Samin, another very interesting revelation for me over the last several cases has been, before it used to be almost 90% people used to ask the question, and now I'm chatting. It's moved completely.
Ready? Yep. Beautiful. That's as long as the message, the question has been answered. Yeah. This is the septal. Let's keep this picture.
The only thing is
So
we may not have enough of the.
how
Oh.
concerned
No, we'll be
are
okay.
you with the dye, extensive dye extravasation there?
That's okay. We're not worried about that cloud.
That's okay.
Good. Good.
Yeah. That's more in the wall adventitial, as you see it's not in the.
It is
130,
the
fielder
majority of the viewers.
So hold on, we have the fielder, regular fielder. Give me. How much? Good, good. Leave it there, okay?
And as you have continued to proceed with the retrograde, with how the antegrade looks like, you're not going to be interrupting the anticoagulation yet.
No.
Okay.
ACT is 270.
And is it bivalirudin or heparin?
We are heparin.
Okay. What is the...
And patient is on Plavix.
Got it. Samin, what is your use these days of the percentage of bivalirudin versus heparin?
Yeah, so all the CTOs, which makes about 8-10%, became bivalent of the heparin.
Because of the reversibility.
Yeah, and radial also, and the radial. So we're almost, I would say, like half now. We were probably the biggest user of bivalirudin, or the last adopter, you can say, going away from the bivalirudin. But that's where we are. I mean, we lot of used to use, all bivalirudin, 90+% of cases. Even in the CTOs, the wire perforation we know is better if you're bivalirudin, because you don't have to reverse it, you just have to wait. But if the other frank perforation, there is more chance of becoming more frank perforation if you're not using it. And so that's where we are.
And all the large bore access we do heparin.
Yeah, and large bore access
Patient
also.
on dialysis, we go for on heparin.
Impala and all those. So we're going quite a bit going to the heparin. And now clearly the bivalirudin was a magic drug at one point. But now, knowing that if you have good vascular access, probably it's no longer with those vascular benefit, less bleeding, and it all started by the HEAT primary PCI trial from UK. That since then the mindset had changed, and I think even in earlier trials, with the radial there was no difference anyway. Yeah.
Right. The biggest contributor, I think, has been wrist access.
Yeah.
So Anu, this is the same fine cross.
No, this is Corsair 150.
This
now.
is Corsair.
150 because you are applying the retrograde.
Got it. Yeah, that is where all our Corsair use. Previously, I've noticed for the retrograde.
In the diag.
Too far come backing.
Yep. I'll take it. Good.
No die.
And why do we have it?
This is a regular fielder to get me into that septal.
that is your preferred
Not fielder ST or FSC. Yeah.
surfing wire.
Some die?
Yep.
Some die?
Yeah. So far you are going in the good direction.
I don't
Very
know.
good direction.
No. Yeah.
Kept going in some. We jinxed it
Just
by
remain.
calling
See, we are in
good
trouble
direction.
right now.
Yeah.
That it's not the stent
Well,
is not
that's-
allowing it. I tried to get into the subtle proximal one through the stent strut, would not go.
But the connection was not much there anyway.
No, the issue is we may not get the Corsair way all the way down.
Okay. Why
So
don't you put a
distal.
Corsair first? All the further.
See?
Goes into the
At the back.
diagonal.
We are struggling here.
Yeah. Let's go further. All the way.
And now would the Corsair go?
Yeah. You are in the main lumen
Look
now.
at the progress there. Yeah, absolutely. And there comes the Corsair. Probably not. Getting stuck at the distal part of the previous stent.
Yeah.
And the wire is beyond the stent.
Turnpike.
Yeah, clearly.
Yeah, turnpike
clearly.
could be. Yeah. What do you think? The Corsair doesn't go. What of the turnpike? Turnpike is about 1.6 French compared to 1.8.
Not even that. If this does not go, are we going to? That is exactly the distal part of that septal.
Yeah.
Yeah.
Was so curly.
Yeah.
See, this perforation can give rise to hematoma, and we have had, though it's just septal, we have had cases of, tamponade. What is that? Want to be aggressive here? I don't want to be aggressive. Let's try the first septal itself.
Get a balloon also.
Wait, what balloon?
2.5 balloon compliant. Just to,
For what?
if you want to change it.
No, it is not going to
Okay.
go.
Question is, we can put a small balloon. Yeah.
To provide
And
you
give
support
the
for
yeah.
the.
Yeah, or just the edge. So there is something at the
Why-
edge of the stent. So with the balloon, you can straight it up.
Why even a 2? Why not a 1.5?
I think just to give a little extra room there. Yeah.
Right. Okay.
Good.
Yeah,
Want to get
because
the
the
dark wire?
I think
Corsair
this
is definitely
this is
not advancing.
going. Let's try the proximal. If you have two issues,
Okay, play.
That is not
So
going.
see which one else is there.
none probably.
Huh?
I'll try again proximal.
Okay.
So Anu, the real decision to stay away or move away from the distal septal is because of the inability to advance the Corsair?
Yeah.
Yeah.
Which we knew. There are
Yeah,
two
would
things.
happen. Yeah.
Yeah.
This is also a very tricky approach, very angulated septal.
Yeah.
It's in a different path,
Not
I
a
think.
go.
No, this is a very early septal. You want to go second one.
Yeah. That one is not going either.
In
Hold
the
on.
mid portion of the stent.
Yeah, that's right.
Even that doesn't have a very clear path. So
You have to make a new curve now.
Not only in this particular case, maybe also with the bifurcations when you're doing all
Get us a
sorts of
fielder,
strategies. Is there a particular wire you've seen which is more beneficial getting you through the struts of a previously placed stent?
Oh yeah, definitely. I mean, I would say the fielder or the whisper. Both are whisper. Actually, I found even much better than fielder. Going through the struts. Definitely, run through is not your wire for that purpose.
Right.
Run through BMW are not the wires. But fielder, I mean, to me, in that situation, it's actually whisper. It's far superior than. Let's see with this one now. Go further.
Hope
It
that
goes
is
with this
a
loop. Yeah.
useful tip for people because
Yes.
that happens often. So,
Yeah.
I mean, here is a question. Try with third septal and corsair excess with cyan black.
Or blue. We have cyan blue or black. I don't think we carry the black. We may have. What do you need now? You need a.
Take the wire.
Which
no,
one?
I just need what's that other you want? Fielder?
We have the fielder XC and FC.
Get me FC.
Okay. All right. Good.
Question is, did the stent go not into the DAG, right?
No.
Just at
Looks
the
to
level.
be to be short of it, but
Yeah.
it did strike me right in the first picture you took. It may be actually,
Huh?
maybe not sure.
Yeah.
Yes.
Yeah.
That's
in
the
the
reason
diag.
we are not getting into the
Yeah.
went into
So
the DAG.
so that stent is in the diagonal.
That's
Yeah.
why we
Yeah.
so forget it. That's why.
All right. Let's try this. We have the cyan black. All right.
Nothing
Let's
to do
bring
with
it.
the-
No, but let's bring
okay.
it. Cyan black. Bring the black. Good. Keep going. Yeah.
So what is the feature of the cyan black which you think helps you here?
It's a it's a modified whisper,
Mhm.
in my opinion. So we don't use it. Okay, this is the second. You want to go with the second?
What wire do you have there?
Fielder FC.
Okay.
But they are going to the second septal, but it still will be a challenge there because you have to going to the stent struts.
Also, I'm not so sure it really
Yeah.
has such a nice
Yeah.
This is not a good sign.
sound and yeah, it's the route towards the RCA is all semi-curly cues.
Going away.
Yeah.
Going this way. I need to come to the medial side. Okay, let me see here.
See if it go even there. It goes from.
Yeah.
The question is, can you advance corsair a little more or no? Yeah.
Not
See?
going
This-
easily. See that?
Maybe a small balloon to help you
Yeah.
instead of the corsair. But
I mean, if
Right,
the wire is not making the turn,
right.
and then we want to
Yeah,
destroy
absolutely.
the stent
Yeah.
strut.
Yeah, and create a epicardial event there.
Yeah. There's some
I
calcium
want
in the
to
prox LED.
Thank all
Yeah.
our
Okay.
viewers.
It was very
for their
calcified. You did a rota and stent that time.
excellent feedback.
Okay, open that black.
But you have to go distal for that.
You cannot. I don't to go there and not knowing these wires will not go. See there? They're not making the turn into the RCA.
Direction you need,
Yeah. If they don't go, you destroy it, right?
Let's get the black.
After this, we're done.
Okay. Yeah.
That is also, Anu, the conclusion our viewers seem to have reached.
Yeah. Ready? Yeah. Then bring back the patient.
In how much time would you optimize that?
I mean, Anu's case,
3
usually
months.
but 2 to 3, 2.5.
We
I mean,
need the things
at
to-
least 8 weeks to heal.
I wouldn't be surprised there is a totally different
Antegrade channel.
antegrade channel. Totally different. It may,
See, you
may
can't
just
even make a
create
curve.
enough.
So much slippery.
And that's the cyan
What's
black.
that? Room 6. 6. 6.
Yeah,
Room
you can't
6.
even make a curve on this wire.
Who makes the cyan wires?
Also same Asai
Asahi.
and
Asahi.
Abbott.
So which is Abbott, no? Yeah.
You can go on the
What is the company?
app and check it.
Asai.
Asahi, yeah.
Asai
is
is separate
Abbott,
now.
yeah.
No, not
Used to
Abbott.
be.
They're
Used to be Abbott, but they dissociated.
No,
Wow.
they were never Abbott. Abbott was a distributor.
Marketed. Yeah.
Marketing distributor
But now
for
even they're no longer. Now they
US.
became independent.
Well,
They make their own team.
they may be having some other products down
See?
the line
I'll
too,
make
which
it
we
too.
probably
That's
don't know
fine. Go.
about now.
Yeah. All right. So we'll give it a last try. Question is still you want to try once again the distal wire
Where?
into the third septal.
Oh, if LED is going into the diag, right? That's why I think this is not going through.
Yeah, no, I know.
Way
But
down.
the same way, yeah.
I'll destroy everything.
We can just do the balloon there if that is the case happen. See if this wire goes. Yeah. I would still go to the third septal. Okay, fix it. Tell them. Okay, this is your.
So,
Yeah, where is it going? Going very smoothly.
Okay, some die.
Okay. Sine, your guide has to come in a little bit. Good.
Yeah, not there.
Huh?
Not in the
Yeah.
RCA.
I mean, what is the SUO 03? SU.
So zero.
Yeah.
Actually, yeah, we have that
Yes,
also.
you can go
Yeah.
on the GuideWire website and just check it.
Yeah, we have show 03. This
We
is
have
a
it.
septal.
Septal surfer.
Yeah. Surfing the
that is-
septal.
So that is another suggestion which
We have
has,
it.
Yeah. No,
Let's surf
fascinating.
the septal.
Wonderful feedback.
Yeah.
I'd,
You want to try that?
No.
Huh?
That's it.
Surf the septal. Surfing is okay. Yeah, now. Here.
No, it's not going there.
Yeah, now.
No.
Good. Yeah.
Now we are there.
Yeah. Okay. So you are there now. You want to go to LO?
Hmm.
But now we need to get a small balloon maybe. We need this one will not go. One O balloon,
Did you
right?
see? Room 2 and 4. 1 and 4. Let me see now.
Huh?
No. 1O is not going to do anything. You need 2O. It's not going to go down. To destroy the strut now.
What do you need now?
No, we have to dilate the.
Okay. Come back. Stabilize this. Where the balloon to. Yeah. So let's exchange it. I mean, take that out.
Is turnpike a larger? Longer? 150. Yeah, no, this is 150, no.
Yeah. Wire went back. Wow.
Okay.
Just keep it there. You need a little support.
Nobody's saying 1 and 4. What's happening? Check.
Yeah. Okay. What do we need to do?
We have to take this.
No, but here. You want to stabilize with the. Here. Okay. Trap it. We're going to do a trap with the balloon and take our Corsair out. Is it a turnpike or Corsair? Corsair, yeah. And then we'll take 2O balloon, 2O compliant, to open the ostium of the stent strut.
the
Yeah.
intent would
Go.
be to help you get the Corsair back there.
Yep. Good. That's it.
Why
That's it.
so late?
I'm going up.
Go up. Patient was ready. 7
Good.
o'clock. Okay.
Go. Let's take it out. Okay, I'm taking out.
Yeah, good. Did you go up? Okay.
Okay, I'm deflating.
Okay. See if-
Good.
Parasuram, come here.
Okay, let's get a balloon. What is it? 2. Okay, we go back to same caudal view. Yeah, cranial actually here. Let's go to cranial view. Our RAO 22, cranial 25. Good. Let's see now. Okay, so now we are putting a 2O balloon to open the strut ostium.
Huh? Okay. No, Viper, get 330 wire. If we cross. So we are going with the 2O balloon. So what we did was a balloon anchor to take it out. Samir, did you watch the steps?
Yep.
Wow. This calcium of this LED is not helpful either. Forget it. We may need rota here, huh?
Or we take a 1O balloon first. What do you think?
Yeah.
It's not making the turn.
Yeah.
You need a 1O balloon first. Okay, take this out.
There is a question and a suggestion. The question is how much is the ACT? The suggestion is perhaps do a reverse cart.
Yeah, so first we need to get some device further down. Yeah, we need to go through the same. For reverse cart, basically that you're doing a controlled antegrade dissection. But we need to get our device into the septal, into that collateral, and then the main vessel.
The calcium of that LED and the stent there is not allowing any device to go into the septal.
So reverse cart and anything cannot happen yet till we get our balloon there, that far. So wire is there. Now we are getting some.
Remove this. Disconnect. Look at that.
Even this is, oh yeah, good. It made it.
We need a rota of the septal. Go up.
Okay, good. All right.
The original case when you had stented, the LED had used rotational.
Rota, oh yeah, was very calcified.
Yes.
Good. See if it move 1 second. Yeah. Okay. This is the 1O balloon. Sapphire, don't go more than 12. It ruptures otherwise. Very good balloon, but if you go more than 12, is a trouble.
Ruptured already.
Ruptured already.
Sometimes it's a good thing to rupture.
Yeah. Okay.
12 now.
Get a 2O12 balloon back. Yeah. Good.
Wait. Can Andrew bring the pictures of these wires? The one that we used was cyan black and the SUO wires.
Have you had any experience long-term? Not that we see that very often, that you've gone through struts of previously placed stent. What are the long-term effect? How does it act? You've had some patients who've come back, and the integrity of the struts which have been dilated through balloons or other, they are about the same, or?
Yeah. No. I think, remember, no matter how you do a pot, kissing balloon and all, once you went to the stent struts, the integrity, you actually take away, I would say, polymer, take away some part of the dye, of the drug, and they always come back at that bifurcation level. And that is why all the trial of the stent across, that if you don't need it, don't put do a routine kissing, is based on that factor. That you start doing a routine kissing is a troublesome, doesn't help you. So this is the 2O. You want 1.5 or is it different? This is 2O balloon.
My question is, do we dilate that? The stent strut there.
Okay, we can dilate a little pot type situation. That's okay. I don't think it's a balloon issue. It's the ostium. We need to get 1.5. No, means a strut.
No, so, you have an 8 millimeter balloon, 208.
Okay. So yeah, so clearly that there's no question that no matter how we do, that anytime you go to the side branch is a trouble.
Turnpike 150.
No, first we have to open with the, what you have?
158? No, don't
No,
give me
8.
12. Do we have a 208?
8. We need a short balloon. Huh? Yeah, that's fine.
No. High pressure. And 158 you have?
Yeah. Yeah, let's
Okay.
take this one.
So Anu, just when you have required that or requested it, there was a recommendation from Pawan, short length balloon, sir.
Yeah, yes.
And other people have recommended a Sapphire 10 and
No,
We did.
We did also.
Sapphire we did,
That is the
remember? Yeah.
first one we did.
Turnpike
Yeah.
Gold.
No, that's the one we requested also.
Yeah. So turnpike that we have.
The first balloon that we used that crossed
Look,
was
But
Sapphire.
you have to make some room. Yeah, meaning that strut, because it was very calcified. 3.5 stent, but you need to open the strut. Yeah.
I am just fascinated and grateful for all the interactive session which we have today. Lots of excellent suggestions, and I'm doing my best to faithfully bring as many of those to you. All excellent thoughts.
You have to put a 3.5 balloon first.
In the LED?
Yeah.
Okay.
Open that area more. 3.5, right? No, 3.5. 8 or 12. 8.
Would there be any purpose to even seeing with the imaging how the morphology of the stent expansion is of the LED,
No,
or just go ahead
we
and
know how it's
you know
behaving.
already
Yeah.
from right?
Yeah.
Yeah.
Yeah. Okay, so we are opening at that area. You kind of doing a, same. Anytime you had trouble, other way could be you put a wire into the LED diagonal, put a balloon anchor, and then try the second balloon. So that's another way. But let's dilate this first.
It's time to.
Or time to bring it to the end closure for the second part. Okay,
Go up.
going up. We need a little further.
No. That's what it is.
Okay, 20.
Exactly. Okay.
We also welcome Arun Nagarajan,
Go up.
Yeah.
a nurse working in Ireland. Very good.
Yes, a lot of calcium here, but it's
Go
not
here.
stented. Not stented.
Yeah.
Gritty feeling there.
Yeah, so we don't there.
Good. Go up here. See that the whole thing is not a. Okay, down. Now get me that 1.28. I think if that doesn't go, we call it a day.
Yeah. 1.28, yeah.
We are still 2.2 gray, milligrays with total radiation. Dye. $150. Okay.
And Anu, how much was the ACT?
About 270 still.
Okay.
Good.
I still want to do the gold. Give the gold. If this does not go, we try the gold. The gold doesn't go, we are done.
Gold without even.
Let's see. Maybe it is better
Okay,
because I've had
good.
cases where
Let's
that
see.
has
Yeah.
gone.
Okay.
Don't fight gold. So how to avoid radiation? You see that we are not on the fluoro all the time. Okay. Problem, right?
Should we just go little balloon here?
Okay, try. It's not going to do that. Wait 1 second.
Okay, I'm going up.
I think we are not there. As
Yeah,
it's a
that's okay.
short
That's
balloon.
fine. Yeah, but that's fine. It changes things, morphology. Go again.
Maybe this balloon wires don't have a good body.
Yeah. Yeah, the same. Wire went in, but there's no body.
Okay, good.
Yeah. Yeah, one more try.
Okay, good.
No. Okay.
Get the gold quickly.
All right. Let's get the gold. Turnpike. LP. Gold.
Gold or LP? LP, yeah. We don't carry gold. LP we carry.
LP. So Turnpike has various varieties. They're all shown in that wire app.
Guide wire.
Yeah. Guide wire app. Okay. Flush. Let's see. Good. We can go directly forward.
Felipe, you have the slide for the LP? Oh no, you mean go, just go.
Yeah. We'll go.
Andrew is coming.
Good.
No, I needed all the turnpikes so that we know the varieties. Did I have the slide?
Keep going. Good. We got it.
I guess it may break. Tip has
Huh?
broken in the past. Tip has broken.
Which one? This? Already?
In the past, I've had it.
Yeah. Oh, yeah. All right.
Good
Made it.
suggestion.
We may come back to that in the end.
Which one?
So your slides.
Yeah. I know. Just
Remember,
to show.
still have to present and finish it.
Okay.
Good.
It's not going.
It will go now.
May break. This is.
Advance the wire more. But that's very interesting. The turnpike made the turn when Corsair has a tough time.
We have dilated also.
Yeah, that's also we dial it with a 1.0.
Yeah. Dilated there, dilated proximally, all of them I think contributed.
You want to go, Leo?
Question is the caliber of this septal good enough?
No, it's not making any more turn. Yeah.
Yeah.
I want to advance.
Fishing in a lake with no fish.
Now, if you advance wire, does it go back into the LED? I mean, to the
I'm
proximal
trying.
RCA?
It does not.
It stops there.
Some antegrade die, so we know where we are.
When you're going with
This is
retrograde,
this is a retrograde cart. So now the wire.
Yeah,
That's what
but
they're
see there you
suggesting.
need a balloon or some support to go further.
Yeah.
Cannot. I want to try to change the
Anu,
wire.
another question for you. What is your target ACT?
We are about 280, 290, 270, 280.
So means in the in the CTO,
and
275
here. You see that I'm advancing the guide, I'm pulling back the left main guide, so we just be cautious. That's it.
Yeah.
This is not going further. See, the guide comes out, which is a usual thing, but if we go anymore, only thing that we want to do now, which may not be a good idea, try a different wire, but this is the only wire that tried us. What is the other thing? Huh? Antegrade picture.
Okay. Guide is out.
Wrong picture. Antegrade, I said. Okay, ready?
Yeah.
Good. Go.
So all that the die, this thing has stabilized completely.
Yeah.
Which is how you had felt.
Not to worry about the cloud.
Doesn't the wire there look to be in a? Do you move the antegrade?
You want to try antegrade a little bit quickly?
Yeah, it's looking.
Get things ready with the fine cross.
Fine cross.
Looks like what you were wanting to achieve in 3 months may have occurred there. Looks
Okay, we'll try gentle. Otherwise, I know we've been calling it a day for a very long time, but after this, really done.
Yeah, so let's go quickly so I can finish at least the part of the presentation, and in the end we'll just show. Okay, let's go to the slides, please.
You have another
So
Scion.
we are going with the
Calculate.
Antegrade now.
Give me,
So
give me.
as I said, defining PCI, complexity and risk of in-hospital outcome.
Take it
So
out.
this the data just came from
me another one.
British Society of Interventional Services, BCIS. What they said is that came up with a chip score, that you have a complexity of the intervention, and they came up by their analysis of a large number of patients that came with a 7 related factor with the patient and 6 procedural. So what were there? Patient factor were age more than 80, female sex, previous stroke, previous MI, PVD, EF less than 30, and CKD. And procedural factor was rotational atherectomy, left main PCI, 3 vessel PCI, dual arterial access, planned LV mechanical support, and lesion length more than 60 millimeter. They excluded patient with cardiogenic shock and so. So key is then we say all they put a score for everything else 1 except renal disease put 2 and planned LV mechanical support did 3. So therefore you could have a 0 or you could have a 16 of the score. As you can see here, the 1/3 of the patients have no score, means a 0 chip score, 35%. And then of course cumulatively, as you can see, majority of them that within, if you take 1, 2 or 3, it's combined exactly almost like 60%. And with the increasing chip factor, that you can see that in hospital MACI, mortality, bleeding, acute procedural complication, the higher, basically which individual the chip factor was there. And these are the chip score for mortality. In the middle is the major bleeding, and then the procedural complication. Higher is the chip score, higher is this complication occurred. So clearly seems to be a simple tool which can make a in-hospital mortality, major bleeding, and procedural complication by the number of the chip factors present. So now this is a nice central figure which basically puts everything together. So key is that in 300,000, I think something similar, we actually trying to look into our database also, the simple factor. So what does that mean? So if you take the low risk, intermediate risk or high risk patients,
Pablo,
you can qualify based on the chip score. And you can see here, let's say the low risk, your chip score is less than 6. Your event rate is only 3%. You go to intermediate, 7 to 10. Your event rate become 10%. You become 10 plus, your event rate become 15 to 20%. So key is, this is my kind of, so just like we have the any risk score, you have a low risk, intermediate, high risk, and so TIMI score kind. So if you can make that, so what does it mean? So that you have your strategy planned for these patients, particularly who are the high risk and can have trouble. So you have a full planning strategy there. So key is that
Give me a new one.
Yeah, the 7 patient factor and 6 procedural factors were associated with adverse in-hospital MACI and defined a chip factor. Use of chip score might be a future target for risk modification. So what does that basically mean? That patients who are high risk score, you need to modify. And most important being, so I can tell you there is some issue with the slides today. And so clearly that there's another risk factor with the score. People the editorial was that do you really need? I think it's a very nice score, and I'll put it in my conclusion that how we can modify. So interventional trial, PCI with drug-coated balloon over POBA in a small vessel. Yes, drug-coated balloon versus DS in a small vessel, there were equal outcome, except in patients with the diabetes, drug-coated balloon was associated with the lower TVR in a small vessel and diabetic. Then TICFA on OCT in FFR negative, and long-term outcome absolutely plus. Then the chip, simple clinical and procedural factors are easy to measure and can accurately predict in-hospital MACI and major bleeding, higher events with increasing complexity. This simple chip calculator tool can help to strategize the resources for post-PCI management, because simple patients can be discharged home. This chip tool can also modify pre-PCI strategy by medical optimization of heart failure for low EF, renal, patient with a transradial because of bleeding, and performing planned stage procedure. Don't do multi-vessel PCIs, just do one or two. So 3-vessel PCI was the trouble, as you saw it in this, the chip score. So let's come to our three questions. That following is the true statement about the results of basket small 2 trial. I'm putting it here, not except. Usually I always have a question. Except means what is wrong. Here is what is right. So Anu said that you always put a question of the wrong. I said let's modify it this time. So basket small. What is the true statement? Mackey rates are higher with drug-coated balloon versus DS in diabetic. TVR is lower with drug-eluting stents versus drug-coated balloon in diabetics. TVR is lower with drug-coated balloon versus DS in diabetic. And MACE rates are higher with drug-coated balloon versus DS in non-diabetic, and TVR is lower with the drug-eluting stent versus DCB in non-diabetic. And answer is C. The TVR is lower with the drug-coated balloon versus DS in diabetic. Everything else was equal, as we saw in the basket small 2. Second, the combined OCT FFR trial, no difference in MACE outcome in FFR positive or FFR negative, no difference in MACE outcome in TICFA positive versus TICFA negative, non-significant difference in MACE in TICFA positive and TICFA negative cases, no difference in revascularization in 2, and 5 times higher MACE in TICFA plus versus TICFA negative cases, even in FFR cases. So which statement is correct? And you see the clear cut, the answer is E. That it was much higher in the TICFA positive versus TICFA negative, even in FFR negative cases. The last question of the chip PCI risk calculator associated with higher MACE, Mackey and major bleeding, except. Now this is the wrong answer. Means what is the wrong answer? Earlier 2 questions were right answer. Total 7 patient-related risk factor. Total 6 procedure-related factor. Planned LV mechanical support is the highest predictive risk factor. More than 50% patients and overall planned LV support declined during the study period. Answer there is that not 50%, about 35% had no chip risk factor.
So you could not resist the temptation of going back to the except.
Yeah, third question. Yeah, I said tradition a little bit relevant. All right, and tell us now. Let's go back to the cine.
Just about everybody has been complimenting on so many lessons they have learned today, and I think very deserving would it also be to provide a detailed follow-up. How do you plan for this patient?
We haven't given up yet. Hello.
Right. No,
she has not given up. Let's see.
Completely.
Okay.
No.
Okay, where are we now? Yeah.
I never reached that conclusion.
Yeah.
And it's.
What are you using now? Tell us.
I tried initially. Now this is progress 200. So if you see here, I need to make a connection. So I'm seeing if I can get. Okay, good. That's fine.
Yeah. A little die looks.
No, it's just going into the subintimal area. So I'm trying to see.
I mean, little subintimal and goes into the main lumen is fine. So just to say, when they're saying the reverse cart, you need a little balloon support to go to reverse here, or wire is stuck right there. We are subintimal at that level. Have you taken a cine picture or no?
We have.
Okay.
Do I go with the floppy or this is all subintimal, you see that?
Yeah.
And we tried that before.
It's exactly how we started the case. Want to thank many people who have been actively following this case, including Dr. Harris. Lots of excellent recommendations.
Yeah. What is this now?
No, same as this. That's going into that. I think it's outside. Right there, we are good. I don't know which you can give me that connection.
So let's see in some different view.
Of course, the larger joy and satisfaction is a successful case, but often more lessons learned. Even
from
in
the
a case where, yeah.
Uh-oh.
That's okay. The knuckle, yeah. You want to go with the knuckle?
No,
You can push knuckle more,
it's not
but
going.
without support, can we push a knuckle
No,
further?
it's not going. Okay.
Okay. Yeah, that's it here. What do you need?
Progress 200.
Okay.
Get into
So
the
one last wire
question
being.
is, do you want me to try a start or no to make that
No,
call?
not now. I start off. How will it help? Now, question is with the knuckle. Can we do a more retrograde
No,
dissection?
no.
It does not go further, right? The point is, remember, the all retrograde event or advancement is limited, or largely because we don't have support there. Our core microcatheter is not there yet, and it does not go through that tortuous distal part of the septal connection.
I think I still want to try a starter once. 20, please. Yeah, put it in the water.
Now, that patient will need a connection. How are you? Good, good. We're just finishing.
Do you have the slide of the body of the wires? Ask, you can give me the various kind of inner core. It's not helping at all. It's going outside. You see that? Okay, a starter is there. You may destroy it, SS. Okay. Don't touch
What
it.
do you need now?
Okay, the last wire of the day.
All right. What? Estato? 14 or 20?
20, not 14.
Okay.
20 and 40, they come
20
to
and 40. Hornet is 14.
14.
All right, let's see. To make that connection. Patient is still tolerating okay for the time being?
That's the great thing.
Yeah. Done?
Thanks to Will. Then
Out. Huh? Yeah. Fine. You want to say integrate?
what Antegrade picture?
Yeah.
Okay. Oh. Still you want to try once more fielder or whisper. Let's forget it. It's not gonna happen. No.
No.
Okay.
I would say that
No.
now maybe you want to just try one more of the turnpike, little more push. This is done.
No.
This we can take.
Turnpike I would not.
No, now it may have been softened out. But anyway, what we need to do now? Let's. I think it's
Give me
about
the-
time now.
Yeah.
What do you need? Whisper or what?
Fielder, last. Okay,
Yeah.
I'll try so that you
So
can.
fielder
be
is
happy.
exactly how the journey started an hour and a half ago.
And we end it, yeah. Full circle. We just want to see if the fielder can go. And I'm just telling Anu that try to see if
No, it's not doing anything.
any more for the story. Can go or not, rotate.
No.
No, but I'm saying you have to get your device further.
Guide, nothing is happening. I do not want to touch
Okay.
it because right now it could be
Yeah.
negative for us.
Okay.
See, it's coming out.
Fine. Okay. This is the fielder. Yeah.
Ion black is the same. What's the other one you have, Suo? That's for the surfing.
Okay. Will die.
So there are many other viewers still suggesting all sorts of wires.
Tell us what are the other wire suggestions? We
Well,
had done all of them.
they are suggesting going back to the Gaia for the Antegrade. Not so sure.
Right.
And we've got
Gaia is okay.
Gayatri.
Get the Gayatri again.
people joining us from Jakarta, Indonesia. Robert, welcome to you.
Okay. Gayatri. No, get a new one. Go on. Get a new Gayatri, yeah. I think it will be the reasonable to stop if Gayatri does not go.
Okay.
Okay? Yeah. Good. Yeah, you had to bring your microcatheter further because Gaia will not make the turn.
Antegrade. I think the guide is coming out. Everything is against us now.
Yeah. Good.
1 second. Don't touch it. Good. Last wire has been going on for a long time.
Thankful to the patient also so far. You know, many times what happens in these long cases is the patient's fatigue. Not even that operator fatigue is always there, but patient fatigue is very big. They become very restless and saturation goes down. They start complaining. That's always the factor. This is the RV branch. And remember, presence of a branch at the CTO is a very high predictor of unsuccess. And this is one of the big factors in this case. That we have big branch.
Not are you giving up, neither are people giving up. So here is a recommendation from Dr. Adolfo Lopez. Why don't you get a balloon in the antegrade wire and make the connection with the hard wire in the retrograde micro? Aggressive at this stage.
No, but how?
Because you're not in the septal.
Yep.
You know, it's just in the mid part of the septal. If you go there, you cannot do wire exchange here.
Yep.
That would have been the plan. If we had the microcatheter into the PDA, I would change it to some stiffer wire. But we cannot do that.
Yeah, so I think one of the big limitation here is our microcatheter didn't go further. With vent, wire vent.
Guides are coming out. Everything is coming out. Okay.
I think to me it's reasonable now that we make it here. Yeah. That's always a second time. You know, it's nowadays we talk about quite a bit of second dose booster. So patient Today was the second dose, and we'll come back for booster. Yeah, done. What do you want now?
You keep talking. I want to
No.
try one more thing.
Which wire? We have to find our new wire.
The miracle 6 are gone.
New Miracle 6.
Get me quickly.
Okay.
Oh, you have that other one? So you, let's see.
What is that?
What is it?
So I would say that is same.
Okay.
As you mentioned that it's not necessarily the success, but the lot of discussion. In this particular
Absolutely.
case,
I have never
Yeah.
in 152 cases, I mean, talking about 13 years, I've never been so active answering questions. I mean, I've had, if I was to count, maybe 50 questions from.
Beautiful. So actually that used to be the comment many times in our CCC symposium, that they didn't say any complications. So, I said, whole purpose is
Hold on,
that
something happened. You changed something.
this one, no,
Yeah, you touched something. No, very good. No,
right?
I don't know, something you did. Fluoroscopy has changed, huh?
Good? No. Okay.
No.
Huh?
Bad.
Yeah, right now. Good?
No, it was not 3. Never.
Okay,
Here?
that's fine. Let's finish it. Yeah. Okay. Antegrade little injection. Okay.
Confiance at 12, quickly. That's really the last one. Something, what happened? We don't know.
No.
Fluoro change.
No. Okay. So when we still little persist and make that connection between our antegrade wire and the knuckle of the retrograde wire, which is not able to advance any further. Yeah, now it's okay.
What was it? I knew something.
Just a question from the viewers following us. Are you having any issue with the volume? I mean, I got 1 or 2 notes that, everything is looking perfect from our end here, but sometimes the
No volume.
What volume?
Yeah, I got a note that.
No volume of the PCI, or what they meant?
No. The volume,
volume,
the sound volume that.
Sorry, sound
somebody,
volume. Yeah.
Somebody could not hear. So I just, I'm trying to pass it to Philip in the room behind, and just let's be sure. But looks to be all right.
Yep.
This is where we were, I think. Not good, right?
Yeah.
Somehow we are connecting in a different area. Come out, right?
Yeah.
Okay.
Good. Okay. Out. Let's
Wait.
take the other one out.
Okay, and now.
So now key is when you are taking off your left system out, your guide and other things may suck in. Make sure they are not.
They don't get sucked in. Yeah.
Yeah.
Okay.
So plans for this patient, plans for any management
No, we'll bring
change,
it back. No, this
when
young guy.
in three months time.
Yeah. We definitely will bring him back.
Always document your left system is okay. Biggest thing is dissection, thrombus formation. Left system only now. Okay, looks good.
Collaterals still remain good.
Yeah.
Okay, good. We stop it here. Good.
No, RCA. No.
Okay, we can take a one little picture of the RCA.
Okay, good.
Sine.
Okay, not bad.
Same.
See,
Yeah.
the smoke is half, or never progressed.
Yeah.
Yeah.
So I think we just conclude now.
Your
Yeah.
Anu, that is a very important part, because so many people had reflected on that, and you had mentioned right up there that look, that is not a concern at all.
Yeah.
Very, very mature, very astute observation, and I can tell you, so many people would have stopped at that time, and there were all sorts of concerns and worries and ACT intervals, but excellent.
So you
Final.
want to complete now? Anu wanted to show one slide, right? Complete.
Yes.
No, the wires you had asked, we have that
Yeah.
in our wire. Show it to us.
Yeah. So just so that yeah.
The further
so-
portfolio of the wires, yeah.
Yeah, this is the cyan black and the SU03. You see the tip load, 0.8 core to tip, hydrophilic coating with the polymer jacket. And the other one also has a hydrophilic coating, SU03. So preferred is same. They are talking about septal navigation for the SU03, but what we used was cyan black. So what they are saying, use that, see in the calcific as well as tortuous vessels. That's where I think septal probably was tortuous there.
Okay.
So we wanted to show the core. You have the picture of the core? Not this one. Or turnpike family. What we used was turnpike LP, but you have regular turnpike, spiral, gold. And you can see all the crossing profile of each one of them with the tip load.
Yep. Anything which is available, everything is in part of this GuideWire 8
Yeah.
app. Everything is there, so
Go
detailed.
there, do
Yeah.
a search, immediately you will get all the, just like we show here with bullet points, exactly what you're looking for.
Anu and Samin, I think many lessons have been learned today, particularly the description of the wires is absolutely fantastic. You were both very persistent. I think the patient was given absolutely the finest effort. The plans for the future are right on, and hopefully we'll be able to watch this case in the future. We finish here, and we'll see you on March 15 for our next session.
Thank you.